Hello and good evening, everyone. I am Yashita Tade. I am a second year postgraduate at Shankar Nethralaya, and I welcome you all to the 29th Power. Today, we'll be going through some interesting cases in neuro-ophthalmology. And now I invite Dr. Vidyadharani ma'am to introduce our presenters and our presenter and our panelists for today.
Thank you, Yashda. It's a very happy moment for me to introduce today's speaker, Dr. Madhumita Gopal, who was a fellow and also a very good friend of ours. After finishing her diploma in ophthalmology from Mysore Medical College, she did her DNB at LV Prasad, then a fellowship in Shankar Nethralaya, and currently a consultant in Department of Neuro-ophthalmology at Arvind Eye Hospital, Chennai. She has multiple publications and presentations all over. I welcome Madhu. And moving on to assess this session, we have three eminent personalities who need no introduction, but Dr. Satyakarna is here. He's been a and he is a doyen in the field of neuro-ophthalmology, and currently the director of ophthalmology department in JP Hospital in New Delhi. Then Dr. Varshni Shankar, she's an eminent and a practicing pediatric ophthalmologist as well as neuro-ophthalmologist in Shop Center, Noida. And the third person is none other than the vibrant, most enthusiastic Dr. Shika, who's currently the director of Department of Ophthalmology, a go-to teacher who always tells us, clarifies all doubts, no matter how difficult it is. I welcome you all three to as panelists for this session. Dr. Madhu, and of course, we have our Dr. Mona Khurana, who's a glaucoma consultant, but who has varied interest in she's an ophthalmologist, rather, I could say that way. She has good insights in all aspects. Welcome you,
Very
ma'am.
close to the nerve.
Yes, it's always pallor versus cupping. Okay, and now move on, Dr. Madhu. Madhu, you can start with the presentations.
Thank you, Dr. Vidya. Let me start sharing my slide.
Yes, Madhu.
All right. So the first case I'd like to present is a bit of a controversial topic. A number of people say that this condition does not exist, while a lot of the data does suggest that possibly it does exist. So we'll just go through it, and I'd love to hear the experts' opinions on this. So a 68-year-old female, housewife by occupation, came to us with left eye sudden painless decrease in vision. Now, her history was significant in that she had undergone cataract surgery in April of 2024, and she was absolutely fine. Post-op day one vision was 6.6. However, when she came 3 weeks later, because of a small amount of lens matter retained in the anterior chamber, she underwent an AC wash, and she came 1 month later for a follow-up, and her vision again was 6.6. However, 3 months later, she had a sudden drop in vision. Now, in her past history, she was significant in that she'd undergone her right eye cataract surgery 1 year earlier and had a sudden vision drop in that eye 1 month after cataract surgery. So systemic history was significant in she was a diabetic, an asthmatic, a hypertensive, and was on a hypothyroid medication since 12 years. On examination, her uncorrected visual acuity in the right eye was 2 by 60 and left eye was 636, and which was similar on pinhole as well. The confrontation fields showed an inferior hemifield defect in both the eyes, and she had an RAPD in the right eye. And of course, both eyes were pseudophakic. Her fundus showed her right eye showed disc pallor, while there was disc edema in the left eye. Her OCT-RNFS showed thinning of the GCIPL in the right eye with thinning plus edema in the left eye. The MRI findings, unfortunately, I don't have the images, but they just showed ischemic changes. So a diagnosis of both eyes post-cataract non-arthritic anterior ischemic optic neuropathy was made along with pseudophakia, hence a pseudo-Foster-Kennedy syndrome. Now because this was the second eye of NAION that was involved, she was started on intravenous methylprednisolone 1 gram per day for 3 days, followed by oral prednisolone. Her vision improved from 636 to 618. So now coming to discussion, as we all know, pseudo-Foster Kennedy's, no, unilateral optic disc edema with contralateral optic disc edema due to a mass or compressive effect is Foster-Kennedy syndrome. Any other cause that leads to this is called as pseudo-Foster-Kennedy syndrome. We all know that non-arthritic ischemic optic neuropathy, the risk factors are small cup disc ratio, optic nerve heterosin, diabetes mellitus, systemic hypertension, and hyperlipidemia, obstructive sleep apnea, among other causes or risk factors rather. And it is hypothesized to be due to hypoperfusion of the short posterior ciliary arteries, which leads to optic disc edema and very often an altitudinal visual field defect and defects along the RNFL as well. Now, what do we know about non-arthritic anterior ischemic optic neuropathy and cataract surgery? Now, according to Shu et al., who did a systematic review in and meta-analysis, the other eye involvement, or there is a 4 times higher risk of NAION compared to non-spontaneous NAION in patients who have undergone cataract surgery, with the other eye risk increasing by 3.6 times. Most cases occur within 6 months, with a cluster at 3 days and 6 weeks post-op. The possible mechanisms that have been hypothesized are high IOP, low BP during surgery or just in the pre or post-op period, possibility of regional anesthesia, and post-operative inflammation. Now, this study found only one significant risk factor, so which was more present in PSNAION as in spontaneous as compared to spontaneous NAION, and that was older age. So we did a retrospective analysis of patients over a period of 1 year who developed NAION within 6 months of cataract surgery and compared them with matched for age, sex, systemic comorbidities, types of surgeries, type of anesthesia, and intraoperative complications of patients who underwent underwent cataract surgery but did not develop NAION within that first 6 months. The variables that we then compared were the axial length, the pre-op blood sugar, pre-op blood pressure, and post-op day 21 IOP, because these were the ones that we had access to. So what we found amongst the patients who developed NAION post-cataract surgery, there were 20, out of which males and to females was 8 to 12, with the average age of 66.7. The mean onset of NAION was 3 months following cataract surgery, with 3 patients presenting within the first week. 4 patients had contralateral NAION, with 1 patient having bilateral post-surgery NAION. Systemically, a large number did have diabetes, hypertension, 1 had atrial fibrillation, 2 renal dysfunction, and 1 had a recent MI. However, what is important to note is 5 patients out of these 20 had no known systemic risk factors. Now, coming to the examination findings, there was optic nerve head edema, which was pallid in 5 and hyperemic in the rest. It was documented as contralateral disc as small in 10 patients. The mean vision was 624, but ranged from 66 to half by 60. The other associated findings on the fundus was macular edema, NPDR. 1 patient had vitreous hemorrhage and 1 a retinal choroidal coloboma. 8 had undergone visual fields, out of which 4 had inferior altitudinal and 1 had superior, 2 had inferior nasal, and 1 inferior temporal. 8 had undergone MRI of their brain, and 7 had shown small vessel ischemic changes, and 1 had a pontine infarct. What about the operative and post-operative findings? 16 had immature cataracts, while 4 had mature cataracts. 13 had underwent their surgery under subtenons, 4 under topical, and 3 under peribulbar. 13 were manual small incisional cataract surgeries, which, when we calculated with the number of cataract surgeries that were done during the same period, showed an incidence of about 0.003%, while 7 had undergone a phacoemulsification with an incidence of 0.0004%. There 3 had complications, 1 pre-op and 2 intra-op, and post-op day post-op day 1 average IOP was 20 millimeters of mercury, which ranged from 9 to 38 millimeters. Of these patients who developed the complication, all 3 of them are the ones that presented within 1 week of cataract surgery. When we compare the risk factors, we found none were significant. Neither the systemic risk factors nor the ocular parameters were significantly different between the post-cataract and the control group. So coming to the discussion, Harry in 1980 mentioned two types of PSNA. The immediate one, which was theorized to be because of elevated IOP in the perioperative period, and a delayed where the pathophysiology was more complex. The incidence that has been reported is 1 in 2,500 to 4,000, which is similar to our study. In our study, 5 patients had no known systemic risk factors, and this is similar to Mikali et al., where there was a lower prevalence of hypertension and toughness ratio less than 0.2. MRI findings suggest from our patients suggest that most patients do have pre-existing vascular ischemia, and although some studies have found that cataract surgery does not increase the risk of NCI, most have shown that there is an increased risk. Okay, so one theory for that might account for delayed PSNIon is the production of pro-inflammatory mediators that induce posterior pole edema, very similar to what we get in cystoid macular edema. So, but in our patients, none of them had a significant inflammation on the post-operative evaluation. Now, there is a lack of definite treatment, although steroids have been tried, anti-VEGFs, hyperbaric oxygen, but none have proven to work. Now, manual SICS seems to have a more risk of post-cataract NAN compared to phakic emulsification, probably because of the larger corneal wound and the sudden drop in IOP during surgery, and possibly because of more anterior chamber fluctuations causing an ischemic insult. So, in conclusion, there is likely an association between cataract surgery and occurrence of NAION. However, the incidence is sufficiently low that it does not require specific mention preoperatively. Possibly perioptic fluctuations in IOP is the cause, so these must be avoided in patients, especially in those with the other ION. And we do need further studies to look for possible avoidable risk factors. These are my references. Thank you.
Yeah. Panelists, your comments, please.
May I?
Yes, please.
Okay, so basically in your case, Dr. Madhumita, what is the etiology? What do you think is the possible mechanism?
The other eye, I mean, the second eye when she came, the left eye, there were two surgeries. There was a retained cortical matter, which might have caused some amount of increased IOP, which would have possibly led to, I mean, that's the only thing that has been suggested to cause it. So maybe that might have been a cause, but why would the first eye be involved? I cannot say.
Were the surgeries phaco in both eyes?
Yes, this patient had undergone phaco in both the eyes.
Was it under a block in both eyes?
No, it was under topical.
Okay. So considering that in the study that has been highlighted by you, they reviewed a large number of papers, but they were able to take only 4 in the end. Am I right?
Yes, yes.
Why was that? Only 4 out of a large number of papers were considered for that study.
Because there isn't enough of evidence. The numbers were very small. The analysis was not sufficiently valid. So
they ended up taking only 3 or 4 of those studies. In one of those studies, I remember it seemed to have a number of cases with retrobulbar block. Am I right?
yes, yes. What was theorized, I think, in that study is that now, because of phacoemulsification, the incidence is much less, almost equal to spontaneous NaION.
Yes. And in your case, was subtenon's injection given in any case?
Yes,
Yeah, multiple.
yes. Most of them actually had subtenons, because the standard in Arvind is subtenons for SICS.
Okay. Because I just recently reviewed a paper for IGO where they had a presentation of subtenon's anesthesia for cataract surgery followed by a cranial nerve palsy or third nerve palsy. And then literature showed only one such case before. and the theory was that the anesthetic has gone through the CSF fluid into the optic canal zone, and then the third nerve got affected. Now the thing is, very limited literature on that. But I was just wondering if that subtenance anesthesia also has something to do with the optic nerve circulation.
In our patients, I feel that why 13 had a subtenance was mainly because of the number that that developed NAION post SICS.
Okay.
So I feel that it's more because of the SICS than the subtenance.
Okay. Uh-huh. Okay. Then there's one peculiar thing I thought of, that one of the hypotheses is inflammation causing some kind of a disc edema. Uh, but would it then not be more common in younger individuals undergoing cataract surgery rather than older individuals?
Yes, yes, it should. But are we more aggressive post cataract for younger individuals? And no, we're not. We don't give them higher steroids. No. It's about the
I
same.
don't think so. We follow with the same protocol for younger or unless there is a history of uveitis. Yeah, and then in your case, steroids worked, the vision improved. So do you think the steroids worked or it spontaneously improved?
I feel it's a one-line improvement that is standard with the NAION.
So when you mentioned that, when we have a routine cataract surgery, we don't need to mention about the risk of NAION in routine cases, with the specific mention that if the patient has had an optic neuropathy in the other eye, especially post cataract surgery, then we have to definitely clearly mention it, and under guarded visual prognosis, explain the chances, the risk, and then what we will be doing to prevent it. Right.
Yes.
So, what all can we do to prevent NIN if we know it is going to happen in the second eye?
Possibly, maybe phaco would be a safer option. So,
Okay.
if possible, counsel the patient for phacoemulsification, and if if the surgeon who's doing it is should ensure that the fluctuations of IOP, which is what is the main theory for this, ensure that there is not much fluctuation of IOP during surgery, and even like during entry, a more gentle entry, so that there's not no sudden drop in the IOP. That's possible, and of course perioperative control of their systemic risk factors as well, very strictly.
I have a question to the panelist. Like all these risk factors are immediate post-op or maximum what we can expect 2 to 3 days post-operative or up to a week. But how do we explain and then after a month or up to even 6 months? The surgery has, I mean, you're not sure that really surgery has a relevance to NION.
Yeah, so that's what I was also wondering. Is post-operative AION defined as up to 6 months? Because that is not something which I was aware of. I thought it's in the immediate post-op period is when you attribute it to the cataract surgery.
So as per HERE, it is the immediate one and up to 6 weeks, and delayed up to 1 year after cataract surgery actually.
So is it necessary that we document a disc at risk in all patients with the previous NION? Because of late, disc at risk itself is a mechanical, I mean, risk factor for NION in the absence of other systemic disorders. So in those patients who have a small crowded disc in our surgery consent form, should we also include ischemic optic neuropathy?
No, so if it is a patient with a disc at risk, then the risk of NAION with the latest cataract surgical techniques, it's just the same as what you would tell any patient of NAION. You know, if the patient has had NAION in one eye, the other eye, how you tell around 15 to 25%, or some studies have said 50% chance of the other eye developing. So cataract surgery as such is not, probably adding too much, as Madhu said, only 0.000, because the initial cataract surgery techniques, in 1950, when the papers were published, it was written that one in every 150 case develop NaION after cataract surgery. So the cataract surgery itself at that point of time was a risk factor for NaION. Then it became 1 in 2,000 when the technique evolved with ECC and probably with SICs. Now, latest now, I think it's 1 in 10,000 or more. So that translates to a very lesser possibility of the cataract surgery per se, MICS or phacoemulsification per se, causing the being a risk independent risk factor. It is. I mean, like, but compared to the disc at risk, that takes a large chunk of the main causes 14.5% developing in the other eye, possibility of it developing in the other eye, compared to the cataract surgery itself contributing to any iron. So those patients where there is a disc at risk and you're doing a cataract surgery the first time, the patient's not had any iron in either eye. I don't know if we should mention that cataract surgery might come in the way of what is coming. If somebody is to develop an MI or anything at any time, and you're operating and on table, it happens, that kind of a thing. But and that's why we don't really talk about it in those about this risk to the patients. But where the patient has had this problem, patient is going to ask you that, am I going to develop this problem after this? You can say you're going to develop because your eyes, the shape of your eye is that, not because of the cataract surgery per se. That's, and when you are doing your surgery, if you've had a complication, you're going to convert it into a bigger wound. And in your series, Madhu, I saw that 3 patients did have PCR, and other kind of complications. And
Yes.
then the even the retrobulbar, these are all independent risk factors where you can probably talk to the patients, that where you're doing a black cataract, and you're going to expect some kind of complication. The patients, having pruritus, you're doing it for the first time that eye, you can discuss it up with the patient. And I wanted to ask Satya, you said that that patient had, because of the that injection, third nerve palsy. Was it transient or it was kind of its state?
Yeah, it was transient. The patient recovered over a few weeks. Yes.
Probably because of the anesthetic.
Yeah, I had a
So
couple of questions for Dr. Madhumita. One was, you mentioned that 4 of the patients had a contralateral AION. So
Yes.
then, okay, so then they were counseled for that. That was noted pre-operatively that
So
they, yeah,
no, so what I did was a retrospective study,
yeah.
and so no, it was not counsel. The
Mm.
NAION was not at all of the I be operated. No, it was not discussed at all with them.
Yeah, and the other thing I wanted to ask, the OCT which you showed, it showed a GCC thinning along with edema. So I was just wondering, how early was this post-op? Because would you expect GCC thinning that early? How early was it? Sorry.
But the OCT I did was the second visit of the patient, not the first visit. Possibly, I'll have to check exactly when it was done, but it wasn't immediately after diagnosis.
So there's one more factor I wanted to add. Now, a lot of patients who have had an unfortunate incident after cataract surgery, like retinal detachment and NAION, are very apprehensive for the second eye surgery. They keep delaying it, and it develops into mature cataract or even advanced cataract by the time they come to you. So that is one counseling that is very important, has to be done, because the more mature the cataract, the more the chances of
Yeah.
complication, the more the risk of NAION, if at all. So you need to actually motivate these patients, and that is the most critical part in such patients.
Thank you, sir. Thank you, ma'am. Dr. Enmeke has a question. Mona, ma'am, you have a question?
A very interesting discussion. I just like to ask, would you do any pre-treatment for when you have had it in one eye, and how would you change your phaco parameters or technique for this second eye?
pre-treatment, yeah.
So is there any role of any pre-treatment?
Pre-treatment, see, we usually work them up for their risk factors, right? So, like whatever for NAI, if the patient has had in one eye, usually we run through all the risk factors for that age group, and that is kind of that whatever the treatment for that risk factor is, the pre-treatment part of it. Intraoperatively, probably we should keep low aspiration rate, low and with Centurion, probably a lower IOP phaco where your IOP is kind of maintained. That machine probably can become useful.
Any pre-op mannitol or Diamox, any role of that?
Yeah, if it is a total not see. I mean, like you're saying that for the AC entry, I don't think so. We are doing any of that unless the patient has a hypermature cataract. Dr. Satya, Dr. Varshan.
We always do the other eye under topical. That was the only other thing I was going to mention. We always do it under topical anesthesia. If there's been a AION in the other eye.
Can we proceed with second presentation? Any more questions, panelists?
Of course, I would motivate Shankar Netrale also to do a retrospective study on NAION in post-cataract surgery patients. I'm sure you have a huge amount of data.
Yes, I think there is a small study there already, but yeah, we can look at the years data, So we have 30 years plus data. Sure.
Can we proceed, ma'am, with the next presentation?
Yes,
Any more
please.
questions? Okay. Madhu, you can present the next case, Madhu.
Yeah, 1 minute.
I think we have Dr. Seema also with us. Any question from the audience?
I'll need a minute to reconnect. So I'll just be back in 1 minute.
No problem, Madhu.
Yeah, very interested.
Good to see you. Thanks for connecting.
Thank you. I told you prior that I like the name Powwow. That's why I'm here. Good morning, everyone. My name is Seema Biswas. I'm a former ophthalmologist turned neurologist, and I practice in North Carolina. I met Dr. Shikha and Satyakana in a Neuro-ophthalmology group, and I put in quizzes and we talk a lot about imaging. So my question was, since I'm far away from all these, but I do treat small vessel disease, so any role of placing these patients on aspirin before you do the second eye, or you just treat the risk factors as it is?
We'd rather put them off aspirin. If they're on aspirin, like for topical figures, obviously we're not stopping aspirin too, but not really. What about you, Dr. Satya, Dr. Varshini? You're putting your patients on aspirin for any NAION? NAION patients are put on aspirin?
Ma'am, I think the different studies have already shown that aspirin doesn't have too much of a preventive role for the other eye. So not really, unless it's indicated systemically. If they're diabetics, hypertensives, and they are on a low dose aspirin anyway. But yeah, only if there's a systemic indication for it.
Yes, I agree.
Thank you.
All right. So the second case is another interesting case that I came across and made me think, because we, especially those of us who also see the general patients, get patients with very vague complaints, and oddly, very often after cataract surgery. So then, which of these complaints do we really take seriously, and which of them do we can we like really brush off? So to discuss this, I thought of presenting this case. So a 60-year-old male from Vellore in Tamil Nadu came with complaints of a unilateral right-sided headache since 1 month, but more urgently, for the last 3 days, he said he could see the recurrent image of a TV cricket score in the left half of his field, and it kept coming and going, coming and going. So he had no history of any similar complaints in the past, no head trauma, no seizures. He was not on any hallucinogenic medications. He did not have a history of migraines. Systemically, he was a diabetic, hypertensive, and ischemic heart disease. Then coming to the general examination, it was within normal limits. The rest of his his entire neurological examination was within normal limits. His ocular examinations also were grossly normal, with a little bit of cataract in both the eyes. So, a provisional diagnosis of palinopsia was made, and he was advised MRI of the brain in orbits, which showed a right fronto-temporoparietal occipital subdural hematoma. I'm sorry, this is not playing, but yeah. So, and yeah, so here you can see the entire subdural hematoma, but there was no midline shift. So, a final diagnosis of palinopsia secondary to acute spontaneous subdural hematoma was made, and he was referred to the neurosurgeon, who planned a conservative management because of the mild symptoms that he had. Now, what is palinopsia? It literally translates to against seeing. So, it is a persistence or recurrence of visual images after the stimulus has been removed, and it is also called as visual perseveration. Now, it has to be differentiated from physiological after images, where after we see a bright stimulus and move away or close our eyes, we see a recurrence of this image very often in the complementary colors to the initial stimulus. Now, palinopsia versus migraine aura, it can now palinoptic images can be a part of migraine aura symptoms, and can last a couple of seconds and occur a few times a month. Now, this very interesting article, which gave a systematic review of palinopsia, classified it into two types: the illusory type and the hallucinatory type. The illusory type is certain examples of illusory palinopsias are visual trailing, prolonged after images, and light streaking. These are blurry and short lived and occur in the same location as the original stimulus. The other one is hallucinatory palinopsia. These again can be formed image perseveration or scene perseveration, that are similar to what our patient had. It can have categorical incorporation, where this same image is repeated over other images, and patterned visual spread. These are these hallucinatory palinopsias are isochromatic, that is the same colors as the original stimulus. They are high resolution and long lasting, and can occur in different location as the original stimulus. So this article very nicely summarized the two. Now, an illusory palinopsia is usually secondary to migraine, HPPD, any drugs, or head trauma. These cause cortical spreading depression or diffuse neurotransmitter transmitter or receptor alterations, or can cause diffuse cortical irritation, which can then lead to focal transient peaks in the cortical activity or excitability, or can cause diffuse persistent neuronal hyperexcitability through the visual pathways, and these are considered cause dysfunctions of the visual perception. And these can characteristically, they are transient and paroxysmal, and are low resolution, persistent, continuous, or predictable, and are very much affected by light and motion. The types include single image perseveration, visual trailing, light streaking, and prolonged indistinct after images, and also visual snow, halos, oscillopsia, echinotopsia, and entoptic phenomenon. Coming to the hallucinatory palinopsia, which our patient presented with, these are usually due to postgeniculate cortical lesions or certain seizure etiologies or seizures of unknown etiology. And it is theorized to be because of cortical deafferation, or a focal cortical irritation, or epileptic discharges, which cause focal activation of postgeniculate neurons, which represent images or scenes already encoded in the visual memory. So this is considered a dysfunction of visual memory. So these include pattern visual spread, categorical incorporation, scene perseveration, which our patients seem to have, and formed image perseveration. The symptoms are high resolution, formed, episodic, images which are not affected by environmental conditions and last more than a few seconds. The associated symptoms include complex visual hallucinations and homonymous field defects. Coming to subdural hematoma, the most common cause is head injury, but it can be spontaneous as well. And other causes are arterial aneurysmal rupture, coagulopathies, neoplastic, spontaneous intracranial hypotension, and idiopathic. The symptoms that they usually present with are headache, confusion, ataxia, and hemiparesis. What is of interest to the neuro-ophthalmologist is that they can present with papilledema, cranial nerve palsies, Terson syndrome, and visual field defects. What about subdural hematomas and visual hallucinations? There are a number of case reports presenting this, but none of them were spontaneous subdural hematomas. So, when a patient says that they keep seeing after images even after the object has moved, do think of physiological after images, or or if if it does not fit into that, then possibly a palinopsia. Look for trauma, epilepsy, drug intake, migraine, or if and also of course imaging to look for a space occupying lesion. Yeah, these are my references. The first one, it was a very interesting article where it really made sense of something so complex as palinopsia. Thank you.
Thank you, Madhu. Panelists, please, your comments.
Very nice presentation, Madhu. Dr. Satya, your comments.
Yeah, so one comment about the previous presentation. The study which we were discussing is a very recent one, and from Dr. Helen Mayer, New Zealand. So extensive review of post-cataract surgery NAION, and I would recommend everybody to read through it. It is a very, very detailed review of all kinds of literature. Then this particular paper again, which Madhumita has mentioned about palinopsia, is from Dr. Andrew Lee. And so you can understand it's a very well written article, and everyone should go through it again, because palinopsia simplified, I would say. Palinopsia simplified. One reading and I got the entire picture, whatever Madhumita summarized just now in her presentation. It's a fantastic paper. So actually, I would like to ask Seema if she has had any experience with palinopsia in her patients. Seema?
Yes, still morning. Thank you for the question.
We're just waking up.
No, I'm on call too, so I have to be awake. So to answer Satya's question, yes, I have come across patients with palinopsia, but it's more secondary to migraines or seizures, or if they're on certain medications like mirtazapine or trazodone, or maybe sometimes on oral contraceptive pills, but I do not manage these patients. I do send them to the neuro-ophthalmologist. Yes, but I have seen these patients. And of course, subdural hematoma is bread and butter. I have seen that too, but very rarely that is the presentation that the patient presents to me with.
So Madhumita, is there any way we can document this phenomena when the patient tells you? Because most neurologically affected patients, I understand, Seema, we ask them to draw on a piece of paper what they are seeing, right?
Right.
But here there are so many factors in it. There is the color perception, then there is the reverse color perception, and then the persistence for how many seconds, minutes, and then drawing the whole thing. If it's a complex picture, how would he show you? Is there any way to document this?
I'm sorry, I wouldn't be able to answer that question.
So essentially, we need to believe the patient.
Yes, but considering the history and exam, I think yes. But of course, we go through everything step by step. What is the etiology? Why the patient has presented? What is the context? And you just take it from there.
So as you know,
I have seen patients with palinopsia. Most of my patients that I've seen with palinopsia are those of visual snow syndrome.
Mhm.
So visual snow, it's like, the patient will be depressed, headache, and there is one pattern. And in one patient, there was actual lesion, some old granuloma in the occipital lobe, and that was the reason where, it was actually, there was a primary lesion in the occipital cortex that was causing the visual snow syndrome. Two of the patients had history of taking these drugs, substance abuse. History was there, and another two patients I really couldn't figure out. So adenopsia, the first thing that comes to my mind in the clinic is snow. And neuroimaging is out. And if you want to investigate clinically, I think ERG. I think it has. I mean, like, not all cases. None of my patients have shown any changes in the ERG, but I think there are a few papers. I think who's done a lot of work on visual snow syndrome, Amanda or Claire. Claire. I think Claire has Nozick group Satya. I think Claire has a huge series of patients of visual snow syndrome. She's done a review paper since you were talking about the review papers. There's a good one of visual snow syndrome, and these are the patients that come to our clinic. Palinopsia patient coming to you. Might be actually that of a visual snow syndrome, and you have to evaluate. And the primary causes, very rarely you might find a structural change in the occipital. The cause of palinopsia actually is that there is in the visual cortex 1, there could, or the visual association areas, visual cortical association areas, there is either at the molecular level something happening, or you can really see on the MRI or neuroimaging.
What medications do you prescribe for visual snow syndrome, or is it controversial?
I just refer to the neurologist, and who's also clueless how to manage these patients actually.
I have seen that lamotrigine works pretty good with some of my patients. Also, although I cannot tell you the number of patients, but it has helped. Maybe it takes care of their mood, it takes care of their seizures, and thereby takes care of their symptoms. I do not know. But I've seen lamotrigine works for visual snow syndrome.
Madhu, how long did you follow up the patient and how did you help the patient with?
So I followed up the patient only for about 3 months, and then he was like lost to follow up. I did discuss it with I had sent him to the neurosurgeon because of the subdural hematoma. So they said that because, I mean, even though it was a significantly large, quite a thick SDH, since he was not symptomatic other than this, they just observed him, and yeah, he got better, and most of the follow-up after that was by phone calls, and he said he's absolutely fine, so he's not going to come back to our hospital as of.
Lucky you.
So in your case, it was the hematoma was the cause of the palinopathy. It was the head trauma.
He had no history of head trauma. No
Good.
history of. It was a spontaneous subdural hematoma.
Patient was on blood thinners.
Yes, he was on blood thinners. He was in
Two blood thinners. I've seen a patient of spontaneous. Patient was both on aspirin and clopidogrel, and presented with a 6-nerve palsy. An MRI showed subdural hematoma. So the patient has been taken off the antiplatelet.
I have not asked, actually. I did not ask.
Yes, Durga.
Good evening, everybody. Myself Durga. Madhu, it was a nice case, interesting case. Ma'am and sir, I have a doubt as well as one point. I had reviewed one patient, actually not my patient, but I just saw him as a review. He was actually having similar, like a palinopsia, spectrum of visual snow syndrome. But interesting thing was he had this problem following an episode of CSR. So any of the panelists or the presenters, do you have any experience of any ocular conditions triggering palinopsia?
I don't remember seeing any patient where, retinal or any ophthalmic condition has precipitated palinopsia. I can't really remember any such case.
Okay, ma'am. Whether it was coincidental or because the patient was very clear that he had recovered from the CSR and then he started having, it was a chronic symptom only, like around 3 to 4 years he was symptomatic, very well educated and very well, he just came for a second opinion to SN. Once I saw him as a review, I think Ambika ma'am's patient. And he's under many neurologists. I mean, he's consulted many neurologists, taken treatment for quite some time. And we tried this filter in the neuro-optometry clinic, and he was feeling better with one of the tint, some kind of yellow tinted glasses, which we had given, and then I didn't see him as a follow-up. But that tinted glass was tried for him. So, any other experience or inputs on these, ma'am? The glasses or the filter?
The CSR bit could be because the patient was, the anxiety. The risk for CSR is that stress. This because these patients have some, depression and some psychiatric anxiety is a part of it, of visual snow syndrome. So probably CSR was like the comorbidity of that.
Yes, ma'am. Probably. And on the glasses, ma'am, the tinted glasses or anything that we can try on these patients, how, whether they are really helpful or just reassurance kind of.
I don't think so. There is any literature on that. Advice from the NEC.
Not sure, ma'am. I'll also go through about it, but just thought I'll take all your opinion.
Yeah. So most of the palinopsias, I think, they are managed as also said by the neurologist. Pharmacotherapy can be tried. The drug she was mentioning. We need to keep a neurologist in the loop. We need to rule out the some organic lesion if that's there in the brain. That needs to be our role is to rule that out. And supportive care.
So I have an observation here.
Thank you, ma'am. Thank you, ma'am.
Madhumita's presentation, she when she was classifying palinopsia, she first mentioned physiological after images. Now, I think that is the most common presentation that ophthalmologists see in their clinic. And if I put the fact mentioned by Durga and match it with this, more educated the patient is, more likely that he would have studied about the physiological after images and is going to trouble you with his symptoms until you are able to convince him or her that it is physiological and there is no disease underlying it. Right. And we see it very often. I don't think it is that rare. It's a very common thing with students and youngsters who have read about it on Google or AI and come with that symptom. They don't tell you they've read it, but they'll say, we see this, see that, and we see this, and you see off. And then we explain it to them, it is physiological, and then they get it. So I don't know, then after us, how many other people they go and trouble about that. Okay. That is one. Second is one observation again that the neurologist here said that he refers these palinopsia to the neuro-ophthalmologist. Neuro-ophthalmologist said that we refer it to the neurologist. So I was just wondering one more. Yes, Seema, yes. Can't hear you.
It is unfortunate for us. The neuro-ophthalmologists are such a rare species to get into. With them, it's like 6 months of waiting. But palinopsia, definitely, I do refer to them because I think they do a better workup than we do. So
whenever you don't find a neuro-ophthalmologist, send the patient to India.
Oh, definitely. Medical tourism. Yes.
Yeah, exactly. It will work out cheaper for him, by the way.
Surely, thank you. I'll keep that in mind.
And we'll find the answer. This other thing which I noticed is maybe it's not reported, but don't you think that most of these palinopsia patients who probably have migraine and seizures or maybe not seizures, migraine and some other of these underlying causes like drug induced and all, with anxiety and stuff like that, might be going to the psychiatrist?
Oh, yes, definitely. They play a major role. So we do refer them if they are uncontrolled and they still have these disabling images, because driving is very important for them and they might feel that it's debilitating. We do refer them to behavioral health and psychiatry too, after referring to the neuro-ophthalmologist.
I also mean that in literature, I mean, when it's mentioned in maybe ophthalmology literature is mentioned in neurology literature, but I'm not sure whether it's mentioned in psychiatry literature also. And I don't know if the psychiatrists refer it to the neurologist or the neuro-ophthalmologist for opinion. I don't know.
No, Satya, the thing here is that everybody, why neurologist is sending to us and we are sending to the neurologist, is that we all want to rule out a basic organic, like actual lesion in the eye or in the brain. So once that is out, then the psychiatrist and everybody, the pharmacotherapy and whatever the glasses from our side, whatever,
Yes.
palliative kind of care can be given. So,
I think that's the message for today in this case, that when we see a patient of supposed palinopsia, we should rule out organic causes by all means.
yeah, the patient was harboring a subdural there. Nice cases.
Thank you.
Thank you, Madhu. Thank you, panelists. If there are no more questions, can we proceed with the concluding statement?
Yes, please.
Mona ma'am, to you.
Okay.
Thank you, ma'am.
So that was a very interesting discussion and very interesting cases by Dr. Madhumita, with excellent discussion and points by Dr. SK, Dr. Shikha, Dr. Seema, Dr. Varshini, Dr. Durga, and beautiful moderation by Vidya. So let me start with the summary first. So crystal clear results from a cataract surgery are expected as it's becoming more of a refractive surgery. But the condition which we discussed, like NAION, was when the surgery takes a dark turn with a pale disc. So, second eye NAION, the risk factors are like hypoperfusion, changes in IOP, high or low. Inflammation was questionable. Regional anesthesia, especially subtenons, could be a risk factor. And like Dr. Vashni said, preferably done under topical. And like everybody agreed, under low phaco parameters without IOP fluctuations. And the definition, like early and late, as we clarified, was 6 weeks, and 1 year was late actually. So what was interesting in Dr. Madhumita's study was that most of the patients had inferior alternudinal or inferior nasal or inferior temporal defects, which are more debilitating. Thankfully, the incidence is really, really low, with a lot of zeros, 0.0003 and 4, which is a happy thing to see. SICS manual is a more risk factor, and steroids, anti-VEGF, hyperbaric oxygen has been tried, but not very conclusively. So should it be part of the consent, maybe for the other eye, especially in, and also not in a disc at risk, but definitely for the other eye of a patient. Pre-op aspirin may not have a role and may need to be stopped, as was discussed. And I think Dr. SK mentioned the paper by Dr. Helen from New Zealand. So going on to the second case, which has got a lot of after images, and this palinopsia should be differentiated from the usual after images, or from migraine aura, or rule out all organic cause. That was the consensus here. And these images, it seems, don't go. They stay with the patient. The patient may have a decreased quality of life, problem in the daily symptoms. And snow is always not beautiful, especially when it's snowing perpetually for you. So Dr. Seema suggested some medications, and patients keep going back and forth between neurologist, neuro-ophthalmologist, and even psychiatrist. So whenever you see a patient, first ensure that it is paranopsia and rule out all organic causes. So I hope I got everything right. So I learned a lot from this discussion, and we're looking forward to the next powwow and seeing you there.
Thank you, ma'am. Thank you, everybody.
Thank you.
Thank you,
very much.
everyone.
Thank
Good
you.
night.
Thank you all.
Bye.
Thank you, Madhumita. Thank you all. Thank you.
Thank you.
Thank you all.